Nice to see you here. So this is on bone and calcium outcome. Here are my disclosures. I have a lot of roles with ILSI separate from this task force. The PICO questions on bone and calcium cover the 4 groups, and you've seen this slide in other contexts many times before. Physiologically, the way it might work, we think the primary place that calcium affects, or that caffeine affects calcium metabolism, is at the kidney, so that with increasing caffeine, you have increased urinary calcium excretion. We're not completely ruling out any of the other effects, but if you have increased calcium excretion, that could lead to a decreased calcium balance that could influence bone and therefore risk of fracture later. We included 14 studies and excluded 26 studies. They were all observational, cohort and cross-sectional, except for 2 randomized controlled trials specifically for calcium homeostasis. They were essentially all in adults except for 1 study that included adolescents. The primary dietary intake: coffee, soda, tea, chocolate, and in categorical groupings, as you've heard before, 1 cup or less, up to 3 or more cups a day. So the outcome measures in this domain included risk of fracture, bone mineral density and osteoporosis, and calcium homeostasis. So the results, when we look at these studies for risk of fracture and fall, we see that the majority, but not all of the data, demonstrate a lack of effect of caffeine. If you have one that has a low L, like Hallberg 2006, an earlier study, this one here, we wouldn't have evaluated that with as much confidence as the later Hallberg study, 2013, which showed a much higher acceptable range with no risks. And the reasons, just to contrast these 2 to give you an example, this 2013 paper was a very strong paper that influenced our decision. There were 61,000 a little bit over 61,000 people considered from the Swedish mammogram study, and the follow-up period was 21 years compared to 13 follow-up years in this earlier study, and there were over 1,000 cases of fracture during that time. So just overall, it was much stronger to base a decision on than these earlier, smaller studies. If you look at bone mineral density, let's pick out that Hallberg analysis again. You see that there is a slight lower bone mineral density value in the same study that they found no fracture risk. So if you have a biomarker on the way to risk of fracture showing somewhat of a concern at a lower intake, but it doesn't translate into any risk with fracture, we just don't consider it quite as strong as the fracture outcome. If you look at this heat map for risk of bias, as with many of the others, the biggest number of red squares is for considering exposure. So you might have them, many of the studies, having categories of 1 cup of coffee or something like that per day or less, up to 3. But I'm a tea drinker, and I know I like dip the tea bag in a cup of water 3 times, and it's almost hot water with a little tea flavoring, whereas other colleagues will put in a bag and just leave it the entire time they drink the tea. So really understanding the exposure of caffeine from that kind of a drink is very different from my 1 cup and someone else's 1 cup. And so we need to improve in that way somehow. The factors that increased or decreased confidence in the body of evidence for fall and fracture overall, we rated the quality of the evidence moderate, and for bone mineral density and osteoporosis, moderate to low. This green shading that you've seen in, for others risk factors shows you that we're in the adequate range for risk of fracture and fall, maybe a little bit more concerned for bone mineral density, but as I told you, this very large cohort that we put a lot of credence in by Hallstrom showed that there was no fracture risk despite a slight impact on lowering bone mineral density. So the weight of the evidence conclusion, the comparator 400 was found to be an acceptable intake that's not associated with significant concern regarding overt adverse effects on bone and calcium endpoints, particularly under the conditions of adequate calcium intake. And I neglected to say that before, but some of the studies that we looked at, the majority of the ones that found no evidence of harm had adequate calcium intake. So you can compensate with a little extra calcium in correcting that loss in the urinary calcium excretion. And the ones that showed more risk did not have correction. They had low calcium intake, so that may be the simple explanation. So we overall concluded a moderate level of confidence with our evidence base, key limitations, inability to fully accommodate calcium intake, high level of indirectness, uncertainty in exposure estimates. And for future research needs, non-adult populations, just across the board, children and adolescents need further study. And that's true for about every health and disease relationship you could discuss. The role of calcium needs to be further probed to see about that interaction more robustly between calcium and caffeine, and then understanding the physiology. So we think we know where most of the effects are at the kidney, influencing urinary calcium excretion, but we don't know the mechanism, and there's a lot to be learned there. Thank you.
Thank you.